Hello students, today we will talk about the features of large intestine. Whenever you are reading the colon, you should first have the idea that what are the embryological basis of the development of the colon. Then we will have the differences, how will you differentiate the large and small intestine, and what are the characteristic feature of the large intestine. So let us discuss that what do you mean by the large intestine, or what are the parts of the large intestine. So the large intestine extends from the ileocecal junction to the anus. So when you will see the ileocecal junction, you have to understand that ileum opens into the cecum, and below that junction you are having the cecum, and above that junction you are having the ascending colon. What does it mean? That suppose at this point, if you are having the opening of the cecum here on the posteromedial aspect, then the part which is below is known as the cecum, and at this point it is continue as a ascending colon. So this is the first thing which you have to understand, that as soon as the ileum opens into the cecum, you are actually talking about the colon, and it extends up to the anus. Now, what is the length of the large intestine? The large intestine is 150 centimeters long, or you can say 1.5 meter long. This is a very commonly asked question in exam. Now, what are the different parts of the large intestine? So, what are the parts? First is the cecum. If you will go from below, then you will have the ascending colon, then you will have the flexure of the ascending colon. So where is the flexure of ascending colon? So this is the hepatic flexure of the ascending colon. Then you will have the transverse colon. Then you will have the splenic flexure, or the turn on the left side is the splenic flexure. Then you will have this descending colon. Now after the descending colon, you are having a S-shaped structure, and this S-shaped structure is known as sigmoid colon. The sigmoid colon is continued downward as a rectum, and rectum will continue with the upper part of anal canal. So these are the areas which are the parts of your ascending colon: the cecum, ascending colon, right flexure, transverse colon, left flexure, descending colon, sigmoid colon, rectum, and anal canal. Apart from that, you are having a very small part is known as appendix. Now appendix is present on the posteromedial side of the cecum, and most of the time you will find appendix retrocecal. So these are the different parts of large intestine. Now what is the embryology of the large intestine? So you should understand that when you will have the gut tube is derived from the endoderm, and it begins to form in 3rd or 4th week of intrauterine life, or the life of gestation. Now it divides into the 3 parts, as you know, foregut, midgut, and hindgut. So when you will see this image, so many times you have seen this image, that this is our gut tube. Now this gut tube is divided into the 3 parts. The part which is actually enclosed, or this is the part which comes in the cranial fold, is known as foregut. The part which comes in the your caudal fold, or the lower fold, is known as hindgut, and the part which is in the middle is known as midgut. So we are having the 3 parts here. Now the important thing to understand, that when you are talking about the large intestine, we are talking about the midgut and hindgut. We will not talk about the foregut. So embryologically, the colon and its the different parts derived from either midgut or hindgut. So we are not considering the foregut, and you should have this thing in mind, that foregut is not going to contribute in the colon or the large intestine. Now the midgut derivatives, if you will see the blood supply, you know that the ventral surface of the aorta gives 3 major blood vessels: celiac trunk, superior mesenteric artery, and inferior mesenteric artery. So you have to remember that superior mesenteric artery supply all the derivatives of midgut, and inferior mesenteric artery supply all the derivatives of hindgut. So this is what you have to understand, that midgut derivative supplied by superior mesenteric, and hindgut derivative supplied by inferior mesenteric artery. Now the next part is that the parts of the large intestine which develops from the midgut. So we have seen the list initially, there is a long list that starts from the cecum. So when you will see the parts which develops from the midgut, it is from your cecum, then appendix, then ascending colon, and right 2/3 of the transverse colon. So these are the parts of your large intestine comes from the midgut. That means these parts will receive blood supply from superior mesenteric artery. Now the hindgut derivatives. Now what are the derivatives from the hindgut? So remaining 1/3 part of your transverse colon, then you will have the splenic flexure, descending colon, sigmoid colon, anal canal, rectum and anal canal. So these parts will develop from the hindgut, but here the important thing is that it is only the upper portion of the anal canal which comes from the hindgut. The whole anal canal does not develop from the hindgut. So this is the only part which you always keep in mind, because it's a very commonly asked question in your exam. So anal canal is having the development from two sources. One is the ectoderm and second is the hindgut, which is endoderm. So my dear students, the terminal end of the hindgut is endoderm, lined pouch, and it termed as the cloaca. Now how this lower part of the hindgut develops, or what are the different derivatives of the lower part of the hindgut? So that is initially known as cloaca. Now if you will see the bird, if you will see the other animals, you will find the cloaca is a common chamber for the defecation, that is the feces, and for the urine. But during the development in human beings or in other mammals, what will happen that this cloaca is actually not remain as a common chamber. A partition develop in the cloaca, and that is known as urorectal septum. That means now you are separating the urinary system from the rectal, that is your feces, defecation area. So into the rectum there is a separation, and it is going to form your upper part of the anal canal and urogenital sinus. So if you will see the lower part of this is the lower part of your gut. Now this lower end, which is known as cloaca, is later on having a septum. Now this is the septum. Now this septum is known as urorectal septum. Now because of this septum, now cloaca is having the two part. This anterior portion is known as urogenital sinus, and this posterior part is going to form your rectum and upper 2/3 of anal canal. Clear? So my dear students, you have to understand that cloaca is a common chamber initially for the excretory system, but later on the excretory system divided into the two parts. Anteriorly you will have the urogenital sinus, and posteriorly you will have the rectum and upper part of anal canal. So when you will see the gross specimen of anal canal, you will find that there is a clear-cut line of demarcation is seen, and that line of demarcation is known as dentate line, or it is also known as pectinate line. So this dentate or pectinate line is actually line of junction between the derivatives from endoderm and ectoderm. As I already told you that if you will see the complete development of the anal canal, it is having the two sources, upper part from the endoderm, lower part from the ectoderm. So in this image, if you will see, if I have to mark the line that is known as pectinate or the dentate line, so this is your line. Now this line is the line, above that you are having the endoderm derivatives, and below that you are having the ectodermal derivatives. Clear? Now the next is, what are the unique features of the large intestine or the colon? Now this is very commonly asked question in your exam. Write down the characteristic features of the large intestine. So you have only 3 words which you have to write in exam. One is known as Taeniae coli, second is sacculation or the haustration, and third is appendices epiploicae. So let's discuss all the 3 in detail one by one. So first is the Taeniae coli. Now what is Taeniae coli? If somebody will ask you, define the Taeniae coli, then your answer should be in one line, that it is nothing but it is a modification of longitudinal muscle coat of large intestine. That's all. So this defines that there are two layers present in the intestine, inner circular and outer longitudinal. But the outer longitudinal muscle, which generally form a sheet or a circular tube around the and it completely enclose your gut tube, is now concentrate at three places. That's why you are having three Teniaes around the large intestine. So let's discuss what is written here. The longitudinal muscle coat form a thin layer wall of the colon. So this is actually the word come is first, it is a longitudinal muscle. Now the greater part of the muscle forms a three ribbon-like bands, and these are called as Teniae. So that's why we are using the word thin layer. Why thin layer? Because majority of the muscle fibers of longitudinal layer concentrated as a Teniae. Remaining fibers are forming a thin layer which has to be thick enough. But around the colon you will find that the muscle layer is thin except these three places where you have the bands. So proximally from which point the band starts? Answer is the base of appendix. It is not only, you cannot write only the appendix, it is the base of appendix. So from the base of appendix, all the three Teniae will start, and then they will cover the whole ascending colon, transverse colon, descending colon, sigmoid colon, and when you will reach on recto-sigmoid junction, these Teniae will disappear. What does it mean? That Teniaes again merge with the remaining longitudinal muscle, and they will form again a proper layer or a thick layer of the longitudinal muscle outside the rectum. So you have to understand that they will present only up to the terminal part of the sigmoid colon, which is known as recto-sigmoid junction. So this is the very commonly asked question in exam. What is the beginning point of the Teniae? Answer is base of appendix. And what is the termination point of Teniaes? Answer is recto-sigmoid junction or the terminal end of sigmoid colon. So in this image, you can see that this is your recto-sigmoid junction. So below that, you will not able to appreciate this band. Now this band is approaching only here, and it will trace, you will find the band all over the large intestine. But in this area, there is no bands. This is the rectum, and this is the important difference between the rectum and sigmoid colon. Around the rectum, it forms a continuous sheet of the longitudinal muscle layer, just like the small intestine. Now, there are three Teniae, and how they are named. They are basically named according to their placement on this portion, that is your transverse colon. Because transverse colon is having the transverse mesocolon. Now transverse mesocolon is present behind, which is actually anchor the transverse colon with the posterior abdominal wall, and that is known as mesentery of the transverse colon. So you will realize that one of your Teniae is present on the border, which is providing attachment of the transverse colon with the transverse mesocolon. And you will find one of the Teniae or the band of the transverse colon will provide attachment to the greater omentum, which reflects from the lower border of the stomach or the greater curvature, passing from the your transverse colon and hang down into the lower pelvis. So my dear students, you have to keep this thing in mind that when you are having the apron-like curtain in your abdominal cavity, that is known as greater omentum, it is suspended from the greater curvature, but somewhere below the greater curvature, it also merge with the band of your transverse colon, and that band or that Teniae now then considered as a Teniae aumentalis. So you have the three Teniae around the transverse colon because it is a part of the large intestine. So one Teniae provide attachment to the mesoentry of your transverse colon, which is known as transverse mesocolon. So the Teniae named as Teniae mesocolica. One Teniae provide attachment to the omentum, which then hang downward, is known as Teniae aumentalis, and the third Teniae is remain free. It is not having any attachment, and that is known as Teniae libera. Libera means free. Clear? So, this is the concept behind the names of the three tinea. So, what are the names? Again I am repeating, the tinea mesocolica, which provide attachment to the mesocolon on the transverse colonic side, not on the body. Second is the Taeniae aumentalis, that will provide attachment to the greater omentum, which is coming from above and going downward. And third is the Taeniae, which is free, which is not having any attachment, is known as free Taeniae or Taeniae libera. So now, if you will see the placement of these three Taeniae, but obviously there is a twisting of the colon occurs. Now you will have the ascending colon, then there is a one turn. Now this turn is present on the right side where the colon twists to provide the turn, and then you will have again one more turn. So in between these two turns, the Taeniae are placement is little bit different from the Taeniae which are arranged on the remaining part of the colon. So first we will see the Taeniae arranged on the areas of your large intestine other than the transverse colon, and this is the placement of the Taeniae on the transverse colon. So first, if you will see the Taeniae libera. Now as I already told you, the Taeniae libera means the Taeniae which is free, which is not having any attachment of the omenta or the mesentery. This free Taeniae or the Taeniae libera is most inferiorly placed on the transverse colon. So if you will see the transverse colon, you will find that this Taeniae is most inferiorly placed Taeniae. Now the Taeniae which is having the attachment of your mesocolon, that means the mesentery of the transverse mesocolon, that Taeniae is present behind. Why behind? Because your mesentery is present on the posterior wall. So you are having the tube which is having the suspension from posterior side. You don't have any mesentery anteriorly. So that Taeniae is known as Taeniae mesocolica, and it is placed on the posterior side of your transverse colon. Clear? Then you will have the third Taeniae, which is known as Taeniae aumentalis. And I already told you that Taeniae aumentalis provide attachment to the greater omentum which is coming from above. So this Taeniae aumentalis has to be somewhere on the superior side of the tube. So you will realize that this is present on the superior part of the transverse colon. More specifically, it is present on the anterosuperior part of transverse mesocolon. So again, please understand this thing. One Taeniae on transverse mesocolon attached inferiorly, which is free. One is posteriorly because it is provide attachment to the posteriorly placed mesentery, which is known as mesocolon. One is superiorly, more anterosuperiorly, because the omentum will go from anterior side and then it will hang downward. So anterosuperiorly you will have the Taeniae is known as Taeniae aumentalis. But when you will see their placement on the other different parts of your large intestine, you will find that Taeniae libera is anteriorly placed on the other parts of your large intestine. The Taeniae mesocolica, which is a posterior structure in the transverse colon, is present posteromedially on the transverse colon or on the other parts of the colon. While the Taeniae aumentalis, which is anterosuperiorly present on the transverse colon, is actually present posterolaterally on the other parts of the large intestine. Clear? So we will first see the normal placement of these, and then you will trace it on the transverse colon. So in this video, if you will see, there are three Taeniae. This is the one, then this is the second Taeniae. So we are tracing the Taeniae first on the ascending colon, and if you rotate more posteriorly, you will find one more Taeniae is here. So one Taeniae is here. You can see this is the Taeniae which is present on the posterior side of this large intestine. Now if you will trace the different Taeniae on the different place, this is the first Taeniae, and this Taeniae is going inferiorly. Now this inferiorly Taeniae is now come here. Now this is the Taeniae libera. Clear? Now if you will see the second Taeniae, you will find that this Taeniae is present on the posterior side, which is now become anterosuperior. Now this anterosuperior placement of the tinea, if you will trace this, it is going downward, is your tinea which provide omentum. So this is tinea omentalis. Now there is one more tinea which is present posteriorly, and you can see that this tinea is most posteriorly here, and it will provide attachment to your transverse mesocolon, so it is known as tinea mesocolica. So my dear students, when you are having the three different teneas, the important thing to understand that their position is different on the ascending colon and the position is different on the transverse colon, but their names are given along the different attachments on the transverse colon. Now, what is sacculation? Now, this is the second characteristic feature. Now, you have to understand that there are two muscle layers, circular muscle layer and longitudinal muscle layer. Both the muscle layer should have equal length, but if the length of circular muscle layer is higher and the length of longitudinal muscle layer is shorter, then what will happen? You have to adjust a big pipe into a small pipe. So in this condition, you are having the folds just like a corrugated pipe which we have below the basins. So what will happen? That the teneas, that means the longitudinal muscle, is shorter. How much shorter? It is 1/6 shorter than the length of circular muscle coat of the colon, and that's why it is responsible to form the pockets of the colonic wall, which are known as haustrations, or they are known as sacculations, which you can appreciate here that these are known as haustrations or sacculations. Clear? Now you have the next is Appendices epiploicae. Appendices epiploicae is again a very important third characteristic feature of your large intestine. Now when you will see the Appendices epiploicae, these are very small fat filled bag of the peritoneum. Now here you can see that when you have the gross appearance of the large intestine, you will find small pouches, and these pouches are the pouches of peritoneum which are filled with the fat. Clear? But these appendages are scattered over the surface of the colonic serosa, that means on the outer side. Now this is something is very important, that Appendices epiploicae, which are the fat containing pouches, are not a vascular structure. Most of the students think that there is no blood supply of these appendages. These are just the fat filled projections. So you can just remove it if you want, but it is not done. It should not be done. Why should not be done? Because these appendages are having a centrally placed artery which are forming the vascular stalk of these appendages. So if you will just pull these appendages, it is going to create a hemorrhage. It will torn the blood vessels. So it should not be done. So these are the most numerous on the side of the sigmoid colon and on the posterior surface of the transverse colon. So this is again the question of your exam, that maximum number of the appendices present in which part of the colon. Answer is sigmoid colon and on the posterior side of transverse colon. Then the second question is that which I already told you, that appendages not present on the appendix, cecum and rectum. Now this which should be always in your mind, that though we are saying that Appendices epiploicae are the characteristic feature of the colon, but they are absent at three places. One is appendix, second is cecum and third is rectum. Now during the surgery, the removal of these appendages, care must be taken not to pull. Why not to pull? Which I just told you, that they are having the blood vessels inside them. So to avoid the traction on the subjacent blood vessels which are present inside the appendages. So there are large intestine, so there are more features of the colon other than these three. What are the features? The large intestine is wider in caliber than the small intestine, that you all know. The caliber is greatest at the commencement. Now what does it mean? If somebody will ask you which is the widest part of the large intestine, answer is cecum. That means at the commencement you have the most wider part of the large intestine. The greater part of the large intestine is fixed. That means it is retroperitoneal. Which parts of the large intestine are not retroperitoneal? First is the cecum, second is the transverse colon, and third is the sigmoid colon. So these three parts of the large intestines are free, and appendix also, because it is having the mesoappendix. So you have the appendix which is having mesoappendix, you have the transverse colon which is having the transverse mesocolon, you have the sigmoid colon which is having the sigmoid mesocolon, and we have the cecum. So all these four areas are not retroperitoneal. Now what about the blood supply of the colon or the large intestine? As already I told you that the derivatives of midgut receive blood supply from superior mesenteric and the hindgut receives from the inferior mesenteric. But there is a pattern of the blood supply. Now here you can see in this image that this is your superior mesenteric artery and this is your inferior mesenteric artery. Now these arteries are forming the arterial arcade on the inner side of your colon. And from this arterial arcade, the blood vessels are arising and they are approaching to the large intestine. So these arterial arcades are known as marginal artery. Or what is the full name of these arterial arcade arteries? These are known as marginal artery of Drummond. So this is the question, what is marginal artery of Drummond? So the colic branches of superior inferior mesenteric artery anastomose with each other on the inner side of your colon, and this anastomosis, you can see a regular channel is formed now, and these are known as marginal arteries of Drummond. From these marginal arteries, you can see the blood vessels are arising. These blood vessels are known as vasa longa and vasa brevia, because some may be longer than they are known as vasa longa, some may be shorter, they are known as vasa brevia. Now, what is the another important thing about the blood supply? That the long arteries divide in anterior and posterior branch close to the mesocolic tinea. Now see, you have to understand this word, that whenever we are having the attachment of the mesentery, suppose in this image you can see that this is your mesentery. Now this mesentery is having attachment here on the posterior side of transverse mesocolon. So I told you that the point of attachment on the transverse mesocolon is having modification of your longitudinal muscle layer, and this collection of the muscles is known as tinea. Now this tinea along this mesentery is known as tinea mesocolica, because this mesentery is known as mesocolon mesentery. Now the arteries are entering along this tinea. So this is the question of your exam, that arteries are approaching to the colon along with which tinea? Tinea libera, tinea aumentalis, or tinea mesocolica? Answer is tinea mesocolica. And you have to keep this thing in mind, that mesocolica is having mesocolon, and mesocolon is containing the blood vessels, nerves, and whatever lymphatics. So this tinea mesocolica is a site from where the arteries are approaching to your large intestine. Now as soon as the arteries are entering or approaching the large intestine, they will divide into the anterior and posterior branches. So here what will happen, that some arteries will go anteriorly and some will go from here to the posterior side. So they will divide into the anterior and posterior parts, and they will make a circumferential arrangement around the tube, that is your colon. And these will pass between the serosa and muscular coat, and they will reach to the A mesocolic tinea. What is A mesocolic tinea? The tinea other than mesocolic. That means you can see here, this is the one and this is the another collection of your longitudinal muscle layer. So these are known as amesocolic tinea. So these are the two amesocolic tinea. So one blood vessel will approach on this tinea, one will approach to this tinea. So because of this reason, what will happen, that the area between these two tinea, that means between the tinea libera and tinea aumentalis, this part of the colon is relatively less vascular. This part is relatively less vascular, and this part is relatively highly vascular area of the colon. So this is the important thing, that longitudinal incision should be made along this line. Which line? The line which is present between these two tenias, that means the tinea libera and tinea omenthalis. So, I should make incision in between these two tinea longitudinally. Now, here you can see the more enlarged view of your blood supply, where you can see that the blood vessels are entering into the mesocolon, and these are the blood vessels which are coming on one side and the blood vessels are going on the opposite side. So, they will divide into the the anterior and posterior parts of your to cover the colon. Now, these blood vessels are approaching to the amesocolic tenias. So, they will go on that side, clear? And these are actually supplying the blood to the different layers, and they will also penetrate till they will reach to the inner epithelium. So, short branches arise either from the marginal arteries or from the long branches. So, we have seen the vasa brevia and the longa. So, what about the vasa brevia or the short branches? So, they may be a direct branch of the marginal arteries, or they may be a branch of your long arteries. Now, these majority sink into the bowel wall at mesocolic border. That means the short branches will not divide into the anterior posterior, they will just go directly into the wall of your colon, and that is your border of mesocolic tinea. The short and long branches together provide the mesocolic region with abundant blood supply. So, this is what I am talking about. This question is there in your clinical based MCQs, that which part of the colon is highly vascular and why. So, if you will see this circumference of the colon here, you will find that this part is highly vascular. There are two reasons. One, the source of the blood is directly from the short arteries, and second, the blood vessels of your longa which are also giving the branches to this part. So, because there are two sources of the blood supply, from the short arteries and from the branches of long arteries, this area around the mesocolic tinea of the colon is highly vascular, while the short arteries are not approaching to the remaining part of the colon. The remaining part of the colon is receiving the blood from these branches of your long arteries, and that is why this area between the two tinea, that is tinea libera and your tinea omenthalis, is less vascular, and this point of entry of the blood vessel is highly vascular. So, it is only the amesocolic region which has scanty or less blood supply. So, this is very commonly asked question when you are approaching the clinical scenario based colonic question. Now, what is the disadvantage of this pattern of blood supply? Now, what will happen? Now, suppose this is a circumference of your colon. Now, here you can see the one important part is this is your Appendices epiploicae. Now, in this Appendices epiploicae, you are able to appreciate that this is the blood vessel or the vascular stalk. So, the first thing which you have to identify, that you cannot just pull this Appendices epiploicae from the surface, because it is having the blood vessel. So, if you will just pull the Appendices epiploicae or the fats on the outer side of the colon, you are actually torn this underlying blood vessel. Second thing is the point of insertion. The blood vessels insert into the wall of the colon at different points, and these points are become weak point. So, bowel wall is weak at what point? Where it is pierced. Now, this word is important, pierced by the vessels, and that points of the pierce is become the site of diverticulosis. That is become the site of diverticulosis. That means the inner side of the mucosa will pop up from these point of the insertion. So, in this image you can see that suppose this is the point of the insertion of the blood vessel. So, this mucosa will pop up, and this pop up area is now known as diverticulum. What is that known as? Diverticulum. So, this is a very commonly asked question, that diverticulosis is common at which points of the colon? Answer is the points where the blood vessels puncture or pierce the wall of your large intestine to approach the inner side. Now, what is the venous drainage of your colon? So, we know that the venous drainage of the colon follow the arterial pattern. What does it mean? That the midgut drains into the superior mesenteric vein and hindgut drain into the inferior mesenteric vein, but up to the your pectinate line. Below the pectinate line, the blood will go into the systemic vein. Now, here you will realize that these veins will go and join the portal system. So, superior mesenteric vein, if you will see in this image, the superior mesenteric vein is, this is the superior mesenteric vein. And where is the inferior mesenteric vein? So, this is the inferior mesenteric vein. So, inferior mesenteric vein opens into the splenic vein. Splenic vein joins your superior mesenteric vein and both of them will form the portal vein. So, whatever the blood of your large intestine, it will drain into the portal vein. Clear? So, this is what you have to understand, that superior mesenteric vein drains from the right colic, transverse colon along with the veins of small intestine, because the part of the small intestine which develops from the midgut, the whole area drain into the superior mesenteric. The part which develops from the hindgut drain into the inferior mesenteric, and we know that inferior mesenteric opens into the splenic vein, and ultimately you will have the formation of your portal vein, and this will enter into the liver. Now, what is the lymphatic drainage? So, for the lymphatic drainage, you are having the 4 sets of the lymph node. One is known as epicolic, paracolic, intermediate and terminal lymph node. Now, what do you mean by these 4 numbers? Epicolic, epi means superior or in front. So, the lymph nodes which are present on the bowel wall, you will have the lymph nodes which are present along the bowel wall. These lymph nodes are known as epicolic. Then you are having the lymph nodes which are present on the inner side of the colon along with these marginal arteries. So, along the marginal arteries you are having the lymph nodes, these are known as paracolic. So, these are the epicolic, then the lymph nodes which are present along the marginal arteries are known as paracolic. Then you will have intermediate nodes. Now, intermediate lymph nodes are present along the branches of mesenteric vessels. That means they are present along the colic arteries, which are the branches of your mesenteric blood vessels. And the last lymph node is the terminal lymph nodes, and terminal lymph nodes are present on the point of origin of your superior inferior mesenteric artery on your around the abdominal aorta. Clear? So, these are the 4 sets of lymph node: epicolic, which are present on the wall of the colon; paracolic, which are present on the inner side of the colon along with the marginal artery. Then you will have the lymph node along with the branches of your superior inferior mesenteric artery, which are known as intermediate, and the terminal lymph nodes which are present around the origin of superior inferior mesenteric arteries. Now, what is the importance of lymphatic drainage? Now, the importance is again clinically based. That means when you are dealing with the carcinoma of the large intestine, you have to at most care about the lymphatic drainage. So, the carcinoma of the colon, the related paracolic and intermediate lymph nodes has to be removed. That means you have to remove 2 sets of the lymph node, the lymph nodes which are present along the terminal arteries and on the branches. So, these lymph nodes has to be removed which are on the branches and along the terminal branches. So, you have to actually remove the segment. You have to cut the colon also, because when you are cutting the lymph node, you are removing that segment. Otherwise, what will happen? If the artery will damage, this part will go under necrosis. So, whenever you are removing the lymph nodes, you have to also remove that segment of the colon which is supplied by that particular branch of the colic artery which is having the affected lymph nodes. Now, what is the nerve supply of the colon? We have already seen the detailed nerve supply in the class, the nerve supply of the GIT, which you can go and see. But here I just brief the nerve supply, that the foregut, midgut and hindgut, there are 3 parts. So, the sympathetic supply comes from the your thoracolumbar outflow, that is your spinal cord. But when you will see the midgut, the midgut derivative supplied by the segments which are T11 to L1, but when you will see the sympathetic supply for the hindgut, it is L1, L2. But what about the main difference is the parasympathetic. The parasympathetic for your midgut is vagus nerve, for your hindgut it is again the spinal cord S2, S3, S4 segments which is having the pelvic splanchnic nerve, or it is known as nervi erigantis. So for this detail you can go and watch my video on the nerve supply. Now what are the functions of the large intestine? Now there are very basic functions. You know that the feces need the lubrication, so there is a lubrication because of the large number of the mucus gland. There is absorption of the water salt, and there is a important thing is that there are floras are present, and these normal floras are responsible for the synthesis of vitamin B in the colon. The last is that there is a mucoid secretion of the colon which is rich into the antibody, particularly IgA group, and it is helpful in the local immune system of your large intestine. So now there are few tables which is there. One is the difference between the small and large intestine. Now there are three cardinal features or the unique features of the large intestine: appendices, epiploicae, Teniae and circulation. So but obviously all the three are absent in the small, and all three has to be present in the large, which is a unique feature of the large. Apart from that, if you will see the dimension, distensibility, but obviously it is small because the diameter is small. It is large because its diameter is large. They are less distensible, it is more distensible. When we will talk about the fixity, the most of the part of small intestine, most part of the small intestine is is having the your mesentery. So most of the small intestine is movable because of the large number of the area of the mesentery. So it is having greater part which is freely movable. But when we will talk about the large intestine, the major portion is retroperitoneal. So major portion is fixed. Now when you will see the histology, you will realize the colon is not having the villi. Colon is not having the plica circularis. So the villi are present in the small intestine and they are absent into the large intestine. When you will have the mucosal folds which are known as plica circularis, they are permanent feature of your small intestine and they are not actually present all time. They may be obliterated when longitudinal muscle coat relax. Now what about the Peyer's patches? Now Peyer's patches is a very characteristic histological feature of your ileum. So it is a main part of the ileum which is not actually seen into the large intestine. And apart from that, if you will see clinically, the large intestine is site of the entamoeba histolytica, dysentery and carcinoma, while the small intestine is a more site of the intestinal worm, typhoid and tuberculosis. There is one more difference between the right 2/3 and left 1/3 of the colon. Now when you will see the transverse colon can be divided into the two parts, right side 2/3 and left side 1/3. And I already told you that it is actually the point of junction between the midgut and hindgut. So what are the differences? So differences is that this portion is supplied by the branches of superior mesenteric artery and this portion will supplied by the branches of inferior mesenteric artery. This portion is having the nerve supply from the vagus nerve. Here you have the nerve supply from the pelvic splanchnic nerve. So these are the basic differences, that right 2/3 occupy till umbilicus, left 1/3 in left hypochondrium. The right 2/3 supply from the superior mesenteric, left 1/3 from the branches of inferior mesenteric. Right 2/3 supplied by the vagus nerve, it is supplied by the pelvic splanchnic nerve, it is derivative of midgut and it is derivative of hindgut. So now at the end of this lecture of the large intestine, now you are able to understand that what is the basic three characteristic feature, what do you mean by the Teniae, how they are named, what are the different important features about the appendices, epiploicae, what are the differences between the large and small intestine. So this is all for today's class. Thank you.